My name is Jay Parkinson. I'm, like I said, trained in pediatrics and preventive medicine. Over the last 11 years, I've spent about $50 million of venture capital money trying to figure out exactly what the internet means to both doctors and patients and how we can do better compared to the traditional old-fashioned exam room. So, that being said, Judd and I are friends. I love what he is doing down there at Jeff Connect, but I'm going to give a different message today, and it hopefully makes you think. Because really what's going on here is I'm pretty disappointed with telehealth. And I really want you guys to think about this statement, because telehealth today is a great option if you are 100% clear you have one of 30 simple issues or need a very low-risk medication, right? So that's what telehealth is today. Its most popular form is the 10-minute video visit. It's a chat between strangers, and they can't connect again. It's really a siloed tool, right? So because, doctors they can't see you, they can't follow up, they don't know what's going on, they just give it a 10-minute snippet in this conversation, it's pretty limited. And the other thing is, why does a doctor need to be seeing pink eye, right? It's just they're practicing way underneath their license. And compared to an office conversation, a video visit conversation suffers from the same inefficiencies of that oral conversation. An oral conversation is the way sometimes humans talk. I would say less over time. But, the other interesting thing about video visits is they just don't happen anywhere else, right? If Apple thought that this was a great way that people wanted to connect, they would have been solving your computer via video years ago, but they just don't, right? So this is a healthcare thing. The other interesting thing about it is that high-quality photos are far better than just a video visit, right? So the tool by design, because of these limitations, it really is just for 30 simple things, like pink eye, colds, simple rashes, that kind of thing. So the most important thing here is no doctor is comfortable. They're not going to be renegades. They're not going to be diagnosing you without confirming something. So because of that, they can't order tests, they can't follow up. It's one 10-minute snippet in an ongoing saga. So that being said, it's just doctors it's not the right way to communicate with patients, is what I'm saying. So a little in perspective, there are 1.1 billion physician visits in America. After 16 years of effort, there's people have said that telehealth is ahead of its time, but it's been around for about 16 years now. The industry leader reported about 1.1 million visits in the last 4 quarters. Notice that 90% of those folks chose the phone rather than video. So while it is slowly increasing, they're pretty unpopular, right, relative to other innovations, especially. So for folks in a study that looked at 20 million people's claims, only about 0.51% of people actually filed a claim for a video visit in a population in the previous 6 months. Kaiser, there's a study published actually, notice the date, yesterday, so you're getting up-to-date information from me. From Kaiser, the CEO has said per year they do 20 million email collaborations, 17 million online prescription refills, 4 million scheduled appointments done online, 37 million tests viewed online. So notice what people are doing. They're logging in and doing transactional things. They're not doing communicative things, except for those emails. That's how people communicate nowadays. So the study in the New England Journal of Medicine yesterday said that from 2015 to 2017, Kaiser only did 210,000 video visits total. There were 152,809 patients across their 12.2 million patients. That's 1.25% of them, which is not far off from the 0.5% in the previous slide. So the other interesting stat there was only about 66% of these video visits actually connected. There were tech issues, there were logistical issues, 2 people coming together, trying to mash up time frames. It's a challenge. So That being said, this is what those video visits look like. As you can see, they were in Q1 of 2015. There were very few of them. There was a significant increase to 2016, another significant increase to 2017, but it looks like they kind of leveled off, right? So they're leveling off at around roughly 1% of people. So if video visits aren't, really taking off, what's the biggest innovation in healthcare services in decades? That's definitely going to be urgent care, right? So there are roughly 7,700 urgent care centers in America. If each does 40 visits per day, which is on the low end of the estimates, there are about 110 million visits per year across the 7,700 urgent care centers in America. That's about 100 times more than a video visit. Both have been in existence for about the same amount of time. Teladoc has been around for 16 years. They've really ramped up in the last 10 years, but so have urgent care centers. So urgent care centers are just destroying the concept of the telehealth video visit. So why is that? I think that's because visiting a doctor in an exam room is a normal, everyday behavior, and that's how we grew up. So look at the rise of urgent care visits. I mean, it's significant over the last 11 years. Look at what's happening. This is from JAMA this month's JAMA as well, looking at how people utilize acute care venues in America. Urgent care is significantly increasing. Telemedicine has just almost zero. Now it's at a few per thousand. So really, why is this, right? You have to look at each of these services, the traditional primary care doctor, the urgent care center, the retail clinic, the video visit, and you have to say, okay, what's the cost? Well, urgent care is about 2x a PCP, retail clinic is about half the cost of a PCP, and a video visit at half the cost, right? So why is urgent care increasing if the cost is actually 2x what a typical PCP is? Well, the number of conditions managed by a traditional PCP is roughly about 1,500. In urgent care, they're not going to do all the other sort of long tail primary care things, but they're going to manage about 300 urgent care issues. Retail clinics, about 50. They can see in person, they can do CLIA wave tests, that kind of thing, so that expands their scope of services compared to a video visit doctor. So in a lot of ways, a nurse in a Walgreens can do almost double what a doctor can do on a video, right? So claims per thousand, as you see, urgent care is significantly higher than really everything else. So that being said, I think today's flavor of telehealth was an invention, really it wasn't based on what people want and how people behave, but an industry-invented tool to recreate an office visit in a video to fit nicely into established billing paradigm. So I think what's going to happen is, like the Segway found its home in cops and tours, the video visit is going to find its home in things like telepsychiatry. Same thing with Google Glass. Google Glass was going to revolutionize how we consume information. Now, where is it? It's mostly found in surgeons. So, where to go from here? There's been a lot of history. We could say that it's early. We don't know if video visits are going to take off, but I feel pretty comfortable that they're not. And the reason why is because how people communicate. Really, there are two different styles of communication in humans, and the new style of communication was kind of unlocked most efficiently by the internet, right? Those two styles of communication are synchronous communications and asynchronous communication, right? An example of a synchronous communication is an exam room, a phone call, a video chat, meetings at work whenever there's 8 people sitting around a table and 7 of them are bored. And then there's asynchronous communication, right? There's emails, that's billions per day. We all know what our inboxes look like. It's insane. Just shoot me a text, that's billions a day. WhatsApp, Facebook Messenger, billions a day. Facebook, Instagram, Snapchat, hundreds of billions a day, right? The transition from synchronous communication to asynchronous communication in humans is one of the most, it's almost as important as, Gutenberg's printing press. This is a huge transition in how we communicate and get things done. So there are advantages to both, right? So synchronous communications, though, they're prone to bottlenecks. Think about it as a doctor going from patient to patient, right? It's a 10-minute snippet in time in an exam room, and if one patient takes you 20 minutes, it's gonna bugger up your entire rest of your day, right? It's a very linear process. Linear processes are prone to bottlenecks. It's bad. Asynchronous is more like you have a bunch of emails coming at you, and you got to triage them and figure out how to do this thing. So that's like managing your inbox. Another part of synchronous conversations are oral conversations. They need to be documented. I said something to you, and now I need to spend 40% of my day actually documenting what I said to you, right? If I don't have to do that, I all of a sudden become 40% more efficient at what I'm doing. So asynchronous communication. The communication is the documentation. And if you can talk as quickly as you can type, that 40% just goes away. So it's almost impossible to standardize oral real-time conversations because we're human. We talk differently, we ask questions differently. But with asynchronous, I can actually ask a standardized question in the right way to everybody that comes at me with abdominal pain, for example. So synchronous communications they're expensive, right? So they take a lot of time and effort. They're actually just tiny snapshots in an ongoing story. And that's what I describe a health condition as, is an ongoing story that a patient has to deal with. And sometimes it lasts days, weeks, months, lifetimes, right? But asynchronous, quick communication snippets, like, hey, I'll be home in 5 minutes, right? You don't need a meeting for that. But that, hey, I'll be home in 5 minutes, or, hey, doc, I think I have a fever now, is a totally new way to communicate with the doctor. Right? It's more frequent, it's more insightful, and it's actually more high-touch care. So, synchronous conversations are very inefficient, they're very expensive. Asynchronous conversations, there's no brick and mortar inefficiencies, there's far less time it takes to communicate, far less expensive to send off quick updates rather than pay for these office visits. And the best way to sort of explain this is a wonderful tool that I love. It's Harvard Business Review's Meeting Cost Calculator. When I hold meetings in my company, I use this. You basically say, at the start of the meeting, you say, how much do you make? I know how much people make. And then you say, how long is this meeting going to last? And then it says, okay, this meeting at the end of a 2-hour meeting costs $4,000, right? That opens people's eyes up to the cost of time very well. So let's look at a PCP's $250,000 salary, which is a good salary for one of them. That's $44 for a 15-minute meeting. Say it's a 3-hour time out of one patient's day. That patient makes $100,000. That's $210 to that person. That's just to get in a room with the doctor and communicate with them. So, if everything at work was deemed super important that you had to call a meeting about it, we really wouldn't get work done nowadays, right? So, not everything needs a meeting. Most healthcare communication does not need a meeting. It just needs simple communication because honestly, that's what healthcare is. It is communication between a professional and a patient, right? That's all it is. Occasionally we use data, and that data comes in the form of tests, imaging, blunt tools like physical exams. It's just, but most of the time it's just asking you questions, talking human to human. So, when time is limited in synchronous communications, there's no opportunity to read up on a situation. So, it's kind of scary that if I'm seeing a patient and I haven't seen this thing in a while, or I do recall that there was some new information that came out 6 months ago, I kind of have to wing it, because I got 10 minutes with this patient, I got to move on. If I go research, the rest of my day is ruined. So, in asynchronous processes, I can say to myself, I haven't seen this in a while. I'm going to go read up on this and then get back to the patient in the most knowledgeable way, right? That is a huge, huge advantage. And really, when time is limited in synchronous communications, there's no real opportunity to call a curbside. I can't just say, hey, Sally, I trust your opinion on this. Take a look. What do you think? Read through this thread. Look at these photos. Tell me what's going on. So, the other issue with synchronous conversations and office visits are, I've only got 10 minutes with this person, don't know when or if I'll ever see them again, and I got to protect myself, so I'm going to bring out the big guns. And I'm going to overprescribe, overdo things, because I don't have the ability to say to somebody, I have a hunch what's going on, but this thing is going to declare itself by tomorrow. I'll ask you for an update in the morning, and then, we'll make a decision from there. But if X, Y, and Z happen, just send me another message or give me a call. Until then, do this to feel better. But that enables me to practice extremely conservative medicine and really use time as a diagnostic tool, which doesn't, you can't do that whenever it's a 10-minute video or phone visit that's expensive. So the other thing about synchronous things is, doctors have to say, hey, I got to be in the office every day from 8 a.m. to 6 p.m. They can't say, I can choose to work from the office, visiting my husband while he's stationed in Vienna, or my summer cabin in Maine. So, in synchronous office visit conversations as well, you're dealing with the patient, you're dealing with the EMR, you're fuddling with all the exam room stuff. Patients hate when you're looking at the EMR rather than you. With asynchronous, you can triage messages, you can respond to messages, you can proactively send messages. It really is just knowing what's coming at you in your inbox and managing it appropriately. So, that being said, what can we learn from all of this? Well, asynchronous communication is really how we get things done nowadays. I've always heard it said that you can be good at work, meetings, or email, but you can't be good at all three. I think it's really important to say, that's how we communicate nowadays. They're highly efficient and they're cost effective. There is a consistent demand for care across the population. We know that. And usage correlates nicely with the scope of the capability of an innovation. If an innovation can only treat 30 things versus 300, people are going to be, by nature, going to the thing that can treat 300 rather than wasting their time with a little simple tool. So we know that care must be available almost immediately. People like that. They can call a Lyft in 3 minutes. And people actually will choose more expensive care if it aligns with their normal behaviors. So that's an interesting insight, I think, from the urgent care craze. So that is, to me, the most important thing here is innovative services have to be aligned with normal human behaviors. So today's flavor of telehealth is a tiny, tiny fraction of telehealth's potential. Some people call it telehealth, but I just call it normal, everyday communication. And I think that's really important to understand. But keep in mind, video visits are not normal communication amongst strangers. So because of those insights, because I thought, telehealth is pretty limited, we're communicating differently nowadays, I wanted to do something that really mimicked how we communicate today. So 7 years ago, I started a company called Sherpaa. So virtual primary care is an ongoing relationship you have with the same doctor throughout all of your health conditions, right? Your doctor says, the main way we're going to talk is online, and I'll arrange in-person care for you with the most appropriate person or facility only if it's necessary. So sometimes I'm going to order labs or imaging, and of course I can prescribe medications. But no matter what, I'm minutes away. Just fire off an email or a message, a secure message via the app. But I'll be a part of your situation for as long as it lasts. I'm your doctor, right? Basically what this means is, because I have this ongoing relationship with you, I can do roughly 95% of what a traditional exam room-based PCP can do. So that's on par with, it's way more than an urgent care center and way more, and just almost as much as a PCP. So to get care, just log into on your browser or via an app and just create what we call an episode of care. That episode of care is going to last maybe 3 days for a UTI, 3 weeks for a pneumonia, or 3 months for a breast cancer scare. I'm going to be a part of that situation, treating you or guiding you throughout. So we're mostly going to message back and forth. And you can share photos, and occasionally, if need be, we'll just jump on the phone, right? But working with me is no cost to you. It's covered by your health plan or employer, right? And that's important. So what is Sherpaa? We hire full-time doctors. Virtual primary care is all they do. We call them virtualists. This is all, they're not in an exam room doing this on the side. This is what they do full-time. Patients have an app. Like I said, it's on the browser. You can log in via Safari or Chrome, or you can fire up the mobile iOS or Android apps. Our doctors, we built our own platform for them. Basically what this is an electronic medical record if it were designed for today's modes of communication. It enables us to message back and forth between patients. We can e-prescribe within the application. We can order labs, we can order imaging, we can make referrals, and we can manage the whole population of our patients. So instead of office visits, we have episodes of care. Think of an episode of care as sort of like an email thread, right? It's like your Facebook feed almost. It is, it's your activity that happens all nested under the main reason why you created that episode of care. So I tell people to don't think of Sherpaa as telehealth. It's not telehealth. It's normal everyday communication. But really, we're just a new, quote unquote, 7-year-old primary care model. So the financial principles here, the reason why we exist, right, is to make low-cost primary care available to people as quickly as possible to prevent inappropriate claims, right? And primary care is not a cost driver. I mean, it's if a hospital network buys a primary care practice, it's probably going to lose money on that primary care practice. It's not a cost driver. So that expensive, inappropriate downstream care is. So you think of Sherpaa as a filter, right? It treats about 80% of everything that comes at us, and that's how we market to people. Come at us with anything, right? Of course, if it is a dire emergency, don't, right? But for anything, if you call your doctor via Sherpaa's app, that immediately rings their mobile phone. They're on call for you, and the group is on call for you. So that connects immediately. There's no answering service in front of it. So that connects immediately to us. For the other 20% that actually get through our filter, we're going to make sure that you're going to be seen in person, and you're going to be strategically directed to the most appropriate specialist or facility. So I always say that Sherpaa is one simple online place to get full scope primary care, and when necessary, a doctor to guide your care through this confusing mess of a healthcare system. And then from there, new care patterns emerge. It's not messy care, it's very appropriate care for, say, a population of 10,000 folks. So we have 150 clients across America. Those are health plans, those are self-insured employers, those are fully insured employers, and then also individuals can join Sherpaa on their own, right? So notice we don't have hospital networks on board here, right? What we're trying to do is really focus on the payers, the self-insured employers and the health plans, to really strategically direct care and bring down costs, because I think that's what our country needs. So Sherpaa is powered by our own primary care doctors. They have no less than 7 years of experience. They're licensed in 47 states. Our main doctor ran Amex's corporate in-house clinic for 15 years prior to coming to Sherpaa 7 years ago. So we don't hire fresh out of residency. These are folks trained mostly here in New York City, out of the great institutions of New York City. So notice we also have mental health psychologists on staff as well, and I'll show you what that means. But we're available 24/7, 365. Arkansas has some pretty backwards telemedicine laws. North Dakota, not too many people for us up there. Alaska's kind of the same. So we're not in those states. So what happens? Members create an episode of care, and employers and health plans pay per episode of care. And keep in mind, it's a flat rate paid per episode of care. This isn't fee for service. We're not gaming the system. We're saying for $100, this is a 3-day UTI, it's a 3-week pneumonia, or a 3-month breast cancer. Now, the reason why it's a flat rate is because, that's kind of what's broken in healthcare today. So we want to basically incentivize doctors to communicate and problem solve, not do volume, right? So how is an episode of care created? It's either created by calling us, or it's created on the app. The vast majority of them are created on the app. So they just click, hey, I'm sick, and then typically people write a paragraph or two about what's going on. They attach photos, and it's really slick on the iPhone app. You just use your camera. If you have any visible symptoms, you just add them. And then you answer 3 basic questions at the get-go, the first time you create an episode of care and use Sherpaa. But So it's very minimal at this point. And then the second you submit your case, our doctors then get a notification on their dashboard that they have a new case. They read the story, they review the submitted photos, and they respond with a broad set of symptom-based questions. And we've built about 300 protocols around the most popular 300 chief complaints, so that every single time, if you come at us with a headache, you're going to get the same 23 questions asked in the same way that our doctors over the last 7 years have really iterated on to make sure that we are communicating as consistently and effectively as possible. So notice when a patient then can respond to those questions, it's free text box, right? So I think this is important for a few reasons. Number one, it's not structured questionnaires. We found very early on that people don't like questionnaires. They want to put things in their own words. And honestly, having things in their own words is much more valuable than yes, no, maybe, right? So that being said, we know that if we send out a question set to folks, we know if it's just sitting there. We know if it's been read and not responded to yet. And so I want to tell you a story real quick. Not too long ago, we sent out a question set on a Friday. Normally, we get these back within an hour or two from patients, but this one didn't come back. And those are the things that bother our doctors because they see that this thing's out there. It's just hanging out. We don't like cases to stall. So Monday morning came along, and we got these responses back. And the woman, she prefaced the responses with, I've been thinking about these answers all weekend. And that hit me so hard because when you're in a 10-minute exam room with a doctor, rapid fire questions, you don't even have time to think, right? But that's why I think our doctors, whenever you say, well, you can't see a patient, you can't examine them, but you should see our histories. And 80 to 90% of a diagnosis is history, is asking the right questions and getting thoughtful answers. So it's a really, there's pros and cons to everything. But I'm just saying that the communication that we have with patients is pretty profound. Sometimes I'm going to order some labs, maybe get some imaging. So that might be blood work at LabCorp or a chest X-ray at a local imaging center. Everything is communicated to the patient within the episode of care. Here are your next steps. Here's where you need to go. The order is waiting for you. Notice the orders are actually faxed out from us via the platform that we built because fax connects all of us in healthcare, like it or not. But it's a great way to transmit information to any healthcare facility in America. And we also get those results back via fax. So we can integrate. That's not the problem we're trying to solve. We're not trying to solve America's healthcare problem. We're just trying to communicate information to folks. So, of course, we built e-prescribing within the app. We work with SureScripts. We built a custom integration and a custom process for prescribing. And I think it's interesting what we do. Notice on the left, when the patient says, I have a new prescription for amoxicillin, you can select your pharmacy or you can decline the medication, right? And that's important because a lot of people, a doctor just, hey, where do you want me to send this prescription? And the patient never picks it up. And the doctor's like, I prescribed this for you. Why didn't you get it? And we want to nip that issue in the bud. We want to say, let us know if you decline this medication and for what reason, so we can jump back in and say, okay, if you don't believe in that strategy, let's create a strategy that's realistic and something that you believe in, right? Because, to me, people talk about compliance. I'm like, well, the doctor just did a bad job explaining why the patient should take this, should follow this plan. So it's all about communication. It's all about being as good of a communicator as possible. Sometimes we do refer you to a specialist. We have about 5,000 specialists in our back end across America that we have vetted and we think are on brand for Sherpaa, and that's who we refer to. Anytime we do refer you to a specialist or a facility, our protocol is to always get that specialist consult back. And notice it is a fax. So it does allow us to refer to anybody in the United States. When we are communicating what something is to a patient, we've standardized the language around the diagnosis. And then, over days, weeks, months, people are just communicating with our doctors, they're problem solving. It's all within this episode of care, right? And so it's very structured. And, whenever you look at an exam room visit, you do the research, and 85% of what your doctor says you forget. It's an oral conversation. It's scary. You don't know what's going on. So with this, literally the entire thread, you can just, I don't understand something. Okay, jump back in and reread it. Or if you've reread it and it's still confusing, just fire off a message. We'll get back to you, right? So within an episode of care, you can also, of course, rate that episode of care. How'd we do? 96% gold stars. About 35% of patients rate us. They also rate the specialists and facilities that we refer to. If we're getting a consistent bad rating for a specialist or facility that we refer to, we just yank them out of the system and we stop referring to them and find someone else locally. So people like us. It's just a different way of communicating with your doctor and patient. But as a patient, what are you doing? You're writing messages, you're sharing photos, you're answering your doctor's messages and questions, you're viewing lab orders, you're viewing your imaging results and your prescriptions and specialists and consult reports and all that stuff. So 95% of all the stuff that happens in these episodes of care are just messaging and photos, right? Only about 5% of the time do we jump on the phone. That's how people communicate nowadays. It's 24/7 for urgent issues. There's a 12-minute response time for a message sent. Like I said earlier, it's an immediate connection via phone. So really what we found is messages plus photos, high-quality photos, plus a phone really is all you need. We've used video 4 times in the last 7 years. So it's just something people don't want and something our doctors who have been doing this for 7 years do not ask for nor think there's value in when people can just pick up a phone and share photos. So that being said, 70% of things can be solved, and we do advertise, come at us with anything you'd go to a primary care doctor or urgent care center for. So 70% of things can be solved in-house with just our PCPs. Talked about that. The other thing that's gotten started about 9 months ago is now via a partnership with Yale, we can invite virtual specialists into an episode of care. And I think this is fascinating because oftentimes PCPs refer to specialists because they don't have the expertise and they need 1 or 2 pointed questions answered, right? So that's what we do. We say, you know what, we call up this dermatologist and say, we don't know what's going on here. Jump into this episode of care, read it, look at the photos, and give me your advice, right? The specialists aren't communicating with patients. They're communicating with us and recommending next steps, right? So those are turned around in about 24 hours, and then the patient, of course, gets that specialist consult, that specialist e-consult as part of the episode of care. And what we found and what this group has found, they have way more customers than just us, it prevents roughly 70% of in-person specialist visits. So who's working within an episode of care with you? Well, I like to think of this episode of care like an email thread, right? Our PCPs can invite people into that thread and get support from psychologists, care navigators, specialists, and services that coordinate surgical procedures. So if you need a surgical procedure, we're going to drive you to the highest quality place at the best price for folks. So I think this is one of the most interesting slides of the presentation. Once members have this one simple online place to go to get care, new care patterns emerge, right? So if you start with us, come at us for anything, 70% of the time, we're going to stop it. It's going to be solved in-house just by us virtually. 10% of those times, we're going to invite a specialist in, and then it's going to stop right there. It's not going to be solved in person. 20% though hey, you need to be seen here. We're not trying to be like, hey, we're trying to pull you out of being seen. We're not being renegades here. We're just saying, let's make this most appropriate for you. So, of that 20%, where do they go? Well, 50% go to urgent care, right? Because it's time sensitive, and PCPs aren't available, and a retail clinic isn't good enough. 10%, you're going to go to the ER. It is a true emergency, or we're working with somebody where urgent care is not open or available to them. about 10% of the time, we're going to send you to a traditional PCP. We're going to say, you know what, Sherpa is great for occasional situations for you, but you really need an in-person PCP. Those are really hard to find nowadays, but we do our best. And that's identifying when Sherpa is not good for somebody, and they would be best suited by a traditional in-person PCP. About 30% of that 20% that gets through us then go to specialists as well. So what can't we do? Well, we can't do physical exams. And I am going to completely agree with Judd in everything he said about the physical exam. It is a blunt tool, and it is only very rarely necessary to make a diagnosis. So we can't do minor primary care procedures, obviously. We can't suture you up over the internet yet. So we choose not to prescribe controlled substances. That is not in our wheelhouse. That's a personal decision we made from day one, and we're probably not going to ever do that. We can't do CLIA wave tests, of course, like traditional doctors can at times, and we can't be in the same physical room as you. I honestly believe that those, the vast majority of healthcare issues that normal people have don't require that really deep, emotional human-to-human connection. A lot of it is just, hey doc, I need my problem solved, right? So whenever you do have that super deep need for a connection, we're going to make sure that you're seen in the right setting with the right person. So the marketing is no cost to the member, because what we want is a new behavior. Go online first. And the messaging is you just go to Google for search. You launch Uber for a taxi, go to Sherpaa for care, right? So this is important because I think this is sort of setting the stage for the future of primary care. How much healthcare do members traditionally consume per year? Well, I call people, there's a super healther. They're about 40% of people, they spend less than $200 a year. Sherpa is perfect for that. Not much of a need, quick fixes, blah, blah, blah. Then there's the kind of healther, it's about 30%. They spend about less than $1,000 a year. And then there's the user, that's about 20% of us, and they spend $5,000 to $1,000 a year. And then there's that power user. We all know the hotspotters, right? The 10% that consume way over $5,000. And that's why I think this is important, because Sherpa is great for that 90%, right? Now, we're not going to be, at this point, great for the super sick, super complicated, but that's not the problem we're trying to solve. And that's why things like Iora Health exist, right? And new hardcore primary care models exist. And that's what we're trying to get people into. So let's take some questions. How about that? I've been yapping so long, and I'd love to hear what you guys are thinking. Yes?
So in that last part of the model, where rather than have, with a minimal set as having to refer out to an in-office specialist visit, you have those virtual e-consults. How do specialists get paid for that?
So it's an extra $100 from the self-insured employer or health plan. So it's a flat $100. And if we need them again, it's another $100. So it is kind of traditional fee for service in that setting.
But they can do it asynchronously.
Absolutely. Yep. And it comes back within 24 hours. Yep. So, any other questions? Yeah.
You showed on your side how more people can be involved. So on the patient side, quite frankly, my wife is way more intelligent than I am, and she asks better questions. So can she be, if I'm your client, can she be involved in the email process and say, hey, Mike's an idiot, you're really sick, what are you going to do?
Yes, I mean, that happens pretty frequently. Whenever you are joining Sherpa, you have the opportunity to invite your family, right? So we know who your family is then. But yeah, I mean, our oldest client is 93, and most of the time he's not communicating with us. His son is on his behalf. Yeah.
Just one question about the chronic condition. What's the episode care and how does it work for somebody with chronic hypertension or diabetes?
Right. It's the same business model. It's the same $100 per episode of care. An episode of care is, and then you say, okay, well, when is an episode of care done in a chronic situation? Basically, what we've come to decide as a group is it's done whenever we think that person is optimized at this time, right? So, we're not trying to game the system. We kind of can't. But, if somebody has diabetes, they're probably going to create, 4 or 5 episodes of care, maybe 6 a year. So that's going to be a $600 total cost for that person. But we're going to be working with them for a month to get their, sugars under control or something like that. So it's more about when does the doctor think this chronic situation is optimized at this point in time?
Yes, one more question.
Listening to this, and I think it's phenomenal. I think there's an amazing way to implement home care and take care of unnecessary extra visits. Over the years, I've been exposed to 2 aspects of this type of care. One is through the patient portal, asynchronous interactions. I am having a super hard time getting patients to really use that. I have very few that do. I think it's a super way, and the documentation is there, so you can save a lot of time. And the other one's a format called Clara. I think it was faulty in that it was being utilized in or used with the EHR and wasn't integrated. But Clara is very similar, and you can get the pharmacist involved, the patients can see exactly what the issues are with the prescriptions, and they can, they can have other people interacting with it. You can just keep tacking on people. It looks exactly like your pictures on the thing, this format. So I guess the frustration I have with these is getting people to accept it and use them.
Yeah.
And how are you approaching that and getting it out there? Because I think your Sherpaa is part of my husband's plan. And I kind of passed it over. I was like, are you kidding? I'm a doctor.
Yeah. Okay, so super good questions. The way I approach this is it's not about technology. This is an integrated full scope service, right? A lot of people think of like, okay, it'd be the same as, well, if I buy an espresso machine, all of a sudden I have a Starbucks, That's just not how it works. You have to say, this is Sherpaa, this is a whole new thing, and Sherpaa is a whole process, and it's a whole service. Now, you have an app, we have doctors. This is how you primarily engage with your doctor. Tacking this on to a traditional exam room doctor, I think is going to be a big challenge because right now you see that, right? Whenever institutions turn on email for their clinicians, the typical message back to the patient is you can expect a response back in 3 to 4 business days, right? So that's because asynchronous processes, virtualists, you got to be dedicated because that patient's going to expect a 12-minute response, not a 3-day response. And you as a doctor seeing patients in an exam room are going to have to work with that patient directly in front of you, and you're going to get super annoyed with all these, it's not only the EMR yapping at you, it's now Sherpaa yapping at you. It's the patient too, it's the nurse, it's all this stuff. Our doctors are 100% focused on just making this happen, and that's what I think is the most important part of understanding that this isn't technology. It really is an integrated service that can't just be tacked on to a traditional practice, I think.
Thank you so much. That was very inspiring. Really, just very